This is Heart Rhythm TV, and I'm Daniel Alyesh, here with a global PFA update from the European Heart Rhythm Association Congress. A lot of interesting data, specifically with regards to PFA coming out here, which we'll dive into in subsequent discussions. I think the most important point about this piece and the impetus for it is kind of to bridge an understanding between the two different practice patterns in North America versus Europe. Important points and facts: in the United States and in North America, 100% of PFA cases are mapped and use ICE. Additionally, even though PFA is roughly only a year old for AFib in the United States, it is already being used in 60% of AFib ablation cases. Now let's contrast that with the European approach. 15 to 20% of those patients are mapped. 5% of patients have an ICE catheter and mapping during the AFib ablation. And despite having upwards of 3 years experience with PFA in Europe, only about 30 to 35% of AFib ablations are actually PFA. So in the subsequent episode and discussion, we'll talk about those practice differences and try to understand, are these science-based differences, practice-based differences, or cultural differences? So stay tuned for the PFA Global Update on Heart Rhythm TV. In the era of PFA for AFib, what do you see as the impact on our understanding and application of physiology to AFib ablation procedures?
Yeah, you're right. But this is, it has maybe been increased with PFA, but it was there before. I mean, from the beginning, mapping of atrial fibrillation has been very challenging. And the initial approach where we were ablating selectively one focus in one pulmonary vein turned out to be not very efficient. So this is how we ended up with pulmonary vein isolation as a concept, because it's anatomically driven. You don't have to wait for mapping, and so that's the first part of the answer. We have to admit that in a large proportion, AF ablation has become anatomical, whether you use PFA or not. PFA makes it easier. But then the other question that is fascinating is atrial fibrillation a mappable rhythm? And so there has been some efforts with different approaches. The complex fractionated signal, the approach aiming at rotor identification that Sanjeev Narayan, and we also worked on that with ECGI. Anyway, none of this turned out to be very convincing. And then Volta now is having good results with an artificial intelligence-based strategy to identify those areas with spatial temporal dispersion and probably rotational activities. And my bias here is that it is very encouraging that Volta has a positive randomized controlled trial. But I think that for AF to be mapped successfully, and for the physiology to get back in the game, we will have to have better recording electrodes, meaning to reduce the far-field components that we have in our signals at a present time. And maybe that this kind of new mapping catheter will allow for some algorithms that are going to be able to provide us with some understanding of what is happening during atrial fibrillation. That's my hope, because we still don't understand what is happening during atrial fibrillation. We don't.
Especially in persistent AFib, I think that's a particular challenge.
Yes.
There's always a technique that we espouse and we say, oh, maybe it's CAFE, maybe it's rotor. Right now, it's intracardiac AI that's probably combining a lot of these concepts, but we need reproducibility of those data, just like everything else in the past, before we can hang our hat on it.
And then it is even more complicated, because once you have identified areas of interest, what is the appropriate or most appropriate ablation scheme. That's also largely unknown. And what we have learned from the past is that there was some benefit in the rotor chase. In some ablation was convincing, but then we had in some patients some man-made atrial tachycardia that were originating from these incomplete ablation that were not connected to anatomical obstacles. So this is a complicated issue, but that's also a fascinating one.
So to summarize what you're saying, I think to map AFib, we need to understand the physiology, which is still very much open for investigation.
Absolutely.
Here's my question for you. As it stands in the current era of PFA, 15 to 20% of AF ablations in Europe are actually using mapping these days. A lot of them have gone the direction of X-ray guidance. Okay.
Yep.
Do you anticipate, with new technology coming forward, that number will increase? And why is there such a difference relative to North America?
These are very good questions. I'm not sure I have all the answers for you. What I can say is that when you do PVI, you don't map. You just collect points in a 3D space to reconstruct a geometry. But this is not mapping. That's not my definition of mapping. I mean, electrical aspects are ignored. And at this pre-ablation, you don't care much on how the vein is activated. This is not going to impact your ablation, right? It's going to be PVI anyway. So from that standpoint, working with fluoroscopy turned out to work. We may be even superiorly successful with the durability of the isolation of the veins. If we have some degree of control on the rotation of the device or on the side where we perform the ablation, this is possible. But I think the gain will probably be marginal. In the real question to me is persistent AF, no question. Here mapping would make sense if we were to understand AF mapping. And the other important point is whether or not by mapping after delivering PFA, you can identify electrograms that are predictive for a higher risk of PV reconnection. That would be great. There were some that were identified with RF. Is this going to happen with PF? I don't know. Some hypotheses are there, but I'm not sure. And the other big difference I suspect between Europe and US is how much general anesthesia you use. Well, that's also a significant difference. But to come back to the use of navigation system, which I think is a better description of what is happening in the US. Pretty much everyone is using navigation system for most ablations. It is an increasing trend in Europe, I think, as well. Not to say that it's, in my opinion, absolutely needed to disconnect the veins. And it's a little more aggressive for patients, general anesthesia, as compared to sedation only, because of the intubation, of course. So it's unclear to me that it would be superior to use general anesthesia systematically.
So I want to change the subject a little bit. Something we were just talking about, actually, about PFA endpoints and lesions, and understanding, hey, what is the optimal lesion set, and the fact that a PFA catheter can become a weapon of mass destruction.
Absolutely.
In nature. I'd ask you to elaborate on some of that discussion.
Yeah, thank you. This is a very important point, and I keep saying I was doing that with RF, but it's even more true with PF, because PF you can wipe out the anterior left atrium. And my vision for AF ablation is that the best strategy is the one that restores sinus rhythm at the least tissue cost. With the lowest amount of destruction, because we should not forget that AF is a complex entity, but part of it is remodeling. So, and remodeling is destruction, and we are adding destruction on top of destruction. So, at the end of the day, it's not entirely satisfying. I would much prefer, as a doctor, to restore the right physiology, so that you get a complete new heart after a procedure. But more seriously, because this is far away, more seriously, I think we have to limit ourselves in what we do, and not ablate everything just because we can, because then we are impacting the hemodynamics of the heart. We are impacting the most likely the risk for thrombus formation, definitely the secretion of ANP, and all of this is not going to be any good to our patients. So let's be cautious and think twice before ablating.
Yeah, I think there were technical limitations around ablating a lot of tissue in the area of point-by-point RF that are different now. Things that work in our favor is the way that the lesion forms, less band-like fibrosis, maybe less stiff left atrium.
Yeah.
However, couple that with we're creating larger lesion sets, and that can create a problem.
Absolutely.
Yeah.
No, you're absolutely right. So stiff LA syndrome is a real problem. I had patients with stiff LA syndrome. I never seen any with PF, but with RF definitely. And this is due to the fact that when you are burning proteins, they retract. So you have retractile scars, and this compromise the left atrial function quite severely in some patients, and particularly the diastolic function of the left atrium, its ability to receive the blood from the lung, so the reservoir function, and even the conduit function probably, but and not even talking about the ejection fraction, which is impaired, of course. So with this respect, PF is much more physiological because it kills the myocytes, but it preserves the architecture of the tissue and the vascularization of the tissue. And this is very important, the vascularization. So, and you see that very well when you do MRI after ablation in your patients. So acute MRI is super dense, bright, late gadolinium uptake with PF. And you never see any dark area in the brightness, which would be hemorrhage or microvascular obstruction. This is never observed. And this is why at 3 months, your MRI is not normal, but showing very little scar according to late guide enhancement because of the preserved microvascularization. So this is also a way to respect physiology that is a plus with PF as compared to thermal energies.
Yeah, very interesting points. So a point about the vasculature, though. I think we've traded concerns in the area of RF with fistula and even phrenic injury. And now we think about vasospasm.
Yes.
And, vasospasm and even maybe longitudinal effects
Yes.
on the vasculature as well. So comment on your current thinking around vasospasm, how you apply PF, do you switch to RF in that region? And what are your concerns moving forward as far as the longitudinal impacts on the vessel?
These are very, very good questions, and nothing comes for free, right? And
Yeah.
in medicine, you never have 0% and 100%.
Yeah.
These are two numbers that you never see. So it is not a surprise, first of all, that we have hemolysis, coronary spasm, things like that. I mean, we had to have some. And the impact on the coronary arteries was described quite some years ago already with some experimental studies. Karsneven, for example, reported some with some impact on the wall thickness of the coronary arteries in those animals. Now, so my way to approach that is that I'm using, like everyone, I guess, when I'm in direct proximity to a coronary artery, which is cavatricuspid isthmus ablation or mitral isthmus ablation, I would use nitrates before delivering. And I've been lucky myself. I never had any issue. I've seen in Bordeaux one case with one of my colleagues where we had a vasospasm. Anyway, what I really think is that RF is not benign either. And I had patients with coronary occlusion with RF, both at CTI and at mitral isthmus. And I think I prefer for my patient to have a risk for spasm as compared to a risk for occlusion that would require PTCA and stenting and etc. Now, if you go deeper into that and have a look to the latest publication by the group of Vivek Reddy on animal experiments, where they compared PF and RF in direct proximity to coronary arteries, you have way more often spasms with PFA, but you have 40% impact on the wall of the coronary artery that is going to last forever and maybe get worse with time with RF as you do with PF. So it is not that simple, and because of that, I certainly don't consider that I should rather use RF when I'm in proximity of a coronary artery. I think it's still not completely clear, and I know that there has been some FFR measurements and also intracoronary ultrasound assessments showing some remodeling of the coronary arteries. These are modest. I'm not sure that RF is any safer than that. Maybe the opposite, in fact.
And then, RF directly over the coronary is definitely
a disaster.
Definitely not safer. Now,
you're right. There is a distance issue.
Yeah, but if the footprint of the catheter is different, and you're able to kind of maneuver around the coronary, whether it's PF or it's RF, that's helpful. Right now, we're stuck with larger footprint catheters with more middle footprint on the horizon. Now, Pierre, I very much enjoyed reading one of your more recent papers. You talked about a very refractory LV summit ventricular arrhythmia, refractory to, I think, multiple RF approaches. And then you applied PFA to that area. And so, I always think of the LV summit as an area of so much high risk anatomy, critical proximal coronary areas,
absolutely,
multiple valves, obviously, and fascicular systems. So talk me through your thinking of applying PFA and how it went in that area.
Yeah, thank you. That was kind of last resort attempt for those patients. I particularly remember one woman. She was on the heart transplant list. Was an amazing load of ventricular arrhythmia that was impacting her ejection fraction seriously. She was 25% or less. And so she had different attempts, RF, you said it, alcoholization of the vein, and nothing worked. And then we thought, well, let's give it a try with PF. And it was interesting because from mapping, it was very clear that it was coming from intramural. Because with the diagnostic catheter in the anterior vein, we had some early but far-field aspect electrogram, and same from the endo. And I think this is pretty typical of this location. Not always, but it's not rare. And so we decided to, in fact, do the ablation, trying to minimize the distance between that putative intramural origin site and the different locations that we could consider for the ablation catheter. And endocardially was more distant than from the aortic root. So we delivered from the aortic root. And from the first delivery, we've got the disappearance of the ventricular arrhythmia. So we gave, I think, 3 deliveries to try to consolidate the results. And here it is difficult decision to make because, as you said, it's a complex area. There is a lot at stake, valves and the left main, and so it is not a very comfortable situation. But what I think is that if you look at the data from literature, the depth that you achieve with PF is not superior to depth you achieve with RF. And this is in healthy animals. Now, in patients with more complex tissue composition, with fibrosis, potentially fat infiltration, it is probably another story. And I think here you most likely have some advantage using PF over RF. I don't know how exactly to explain that, but this is, I think, the most likely hypothesis to explain the major difference between RF and PF in those patients. And so I think that PF in general will probably be a standard in the future for VT ablation as well. Now, PF generators and recipes have not been tuned for ventricular ablation, obviously, so there is some improvement to be made. But even the first generation that has been developed for atrial wall seems to be superior to RF in the ventricles. So that makes me very optimistic for the future, in fact. And if I may have just another word, I think we are about to witness a revolution in VT ablation. And so the bulk of the VT ablation is post-MI VT. And I think that by combining image integration and pulse field with intermediate size ablation electrode, where you just have to go to one isthmus. In one site, you're going to transect that isthmus and then move to the next. This is going to make VT ablation or post-MI VT ablation as simple as PVI, I think. So like an hour and a half procedure with much less stress for both staff and patients.
So, so the fact that there was a redo ablation with that heterogeneity of the impedance in the scar may have helped the PF energy deliver a deeper lesion. And I think you're right. I think treating heterogeneous substrates, which is the essence of VT, with PFA, I think it will be advantageous. Now here's my question for you. Will it obviate the need for epicardial?
That's
VT
a very
ablation?
good point. That's a very good point. So I don't know, but I suspect it potentially could. The important thing to realize when it comes to PF is that there are 12 to 14 parameters that you can play with that will directly and very significantly impact both safety and efficacy. And so it's a multiple and complex equation that you can play with for decades. So there is room for improvement, and I'm convinced that we will have tools that are able to reach the full transmorality with PF in months or years. I mean, Field Medical, for example, is already giving a very significant depth. So it is possible that we will no longer do epicardial approaches. It is really possible.
I mean, the voltage, the shape of the waveform, then where packets delivered, the pauses in between. There are so many things that are proprietary and currently hidden from view that I think eventually, as we gain experience with this, we're going to have to open and I think apply it differently. And I think you're right. I love it when you say that we're on the cusp of a revolution, because I do agree with you. And I think VT is ripe for that kind of.
Absolutely. VT is a very interesting area because everyone considers that the sizable market is AF, but VT is under considered and under evaluated. It is potentially much bigger than what we do at present time.
So final question for you, okay? If you had to get an AFib ablation yourself, okay, What
So-
energy source would you want and why?
Oh, I publicly said that years ago. It would be PF, no question. I mean, the worst complication you can think about is fistula with the esophagus, and that one has completely disappeared with PF.
Yeah.
There has been over 200,000 cases across the world with PF. There has been zero report of fistula. So that's very, very encouraging and important in my opinion. And then there are plenty of advantages. And in general, I consider safety greatly superior with PF as compared to thermal energies. So PF, no question.
First off, thank you for all the work you've done in the PFA space. To give you some context, in the United States, we started doing PFA ablation roughly about a year ago. About 60% of de novo AFib ablations or 60% overall of AFib ablations are being done with PFA now. That's fairly rapid. Now, I want to dovetail that into discussion about mapping. Nearly 100% of PFA AFib ablations in the United States are using mapping. Now, in Europe, my understanding is it's about 15-20% are using mapping.
At the most, yeah.
Yeah. Now, you've done a lot of work in this space. Talk to me about the value of mapping for an AFib ablation from your perspective.
Yeah, well, probably those 15%, that's probably our center that is mapping. So some people consider mapping to not be a necessity in terms of doing this procedure. So they are very much coming from that cryo space, saying that a fluoro-only procedure will still do it. And the same holds true for PFA. My understanding is a little bit different. My understanding is that adding the information of a mapping system allows us to enhance the quality of where and how we deploy the lesions. Let's focus, for example, on the major device that we have since about 4 years in Europe, and we did about 1,000 cases with, which is the FARAWAVE catheter. So, like by rotating this catheter shape, I think it's crucial to really know where your previous position was and how much you have to rotate. Basing that on fluo information only, in my experience, leads to like putting it exactly on the same spot, so to say, just like rotating one of the pedals of the catheter further. The problem is that by like negotiating with my peers, that there's no proof that adding mapping does really add something in terms of the procedure success rates. So from a patient's perspective, there's no data showing that we have better outcomes in terms of freedom from AF or AT if mapping has been used. Also, not the opposite has been shown. So we are a little bit in an open space. And of course, there's cost restraints in Europe, which is a little bit different than in the US, because mapping adds costs and complexity to the procedure. And for example, in Germany, the reimbursement that you get is exactly the same if you map or if you do not map. So it doesn't make a difference at all. It will just increase the cost side with no reimbursement. And since there's no proven benefit, many people decide not to go for mapping. And I think 15 to 20 is even too optimistic. I'd rather rate it to 10% probably.
Mm-hmm. I think it's invaluable to understand your substrate before you do an ablation. And also, post-map tells you how you've done. This has been the standard for a long time. And so, sometimes I say this about PFA, especially, I think it's a lot of an economic discussion, which is you move forward in some spaces. Mm-hmm. It's progress, and then you pull back in others.
Exactly.
And at the end of the day, we look at the outcomes and we say they're similar to thermal, And so, I think, but we're shuffling how we're using tools. This will dovetail into our next question, which is, we had a discussion with Australian EPs, and about 100% of de novo AFib ablations are being done with PFA in Australia. In the United States, as I mentioned, all comers is about 60%. And in Europe, where you have the most experience or the longest access to PFA, and you're at 35%. Explain to me kind of the adoption behaviors within Europe, as well as kind of, why thermal ablation is hanging on probably stronger here relative to other markets.
There's probably a couple of reasons for that. Now, probably one of the strongest reasons is that, as I said, we have, like in most European countries, like a fixed reimbursement for our procedures. And if a device costs significantly more compared to others, like RF point-by-point catheters, for example, the willingness of people to jump onto that and to go to 100% doing those cases is of course limited. There are certain countries like Switzerland, for example, where the doctors have been clever enough to negotiate with health insurance companies a certain new format for reimbursement, a new budget, which is exclusively for PFA procedures, which kind of covers those extra costs that usually come with newer devices. Now we are out of this new device thing because, as I said, we are dealing with this technology since about 4 years already, and still there is a pricing difference in between RF as a conventional or cryo, especially cryo and PFA. Second thing is, in most European centers, in most European countries, we have a lot of smaller centers, and they are very much addicted to cryo traditionally. So these centers buy a cryo system, and they are not immediately willing to jump on another technology like PFA, even though there might be numbers indicating that maybe safety profile might be beneficial compared to thermal energies. But still, most centers will refer to the Advent trial, still limited number of patients, but still showing there is no significant increase in complications or decrease by PFA. And in Advent, there has been one death associated to the procedure in the thermal group. So people will refer to that and say, okay, why do I have to buy another system, buy more expensive catheters for my procedures if I still have my cryo in my lab? And so I'm going to stick to that. And once this cryo thing will break down, I'm going to jump on PFA. So I'm very confident that we're going to have the same process with at least the novo PVIs jumping to close to 100% in the next years. I'm pretty sure. It depends on how long the cryo will still work.
So a couple of comments to what you just said. I think that one of the things that's rung true in all of my discussions with all the different EPs from around the world is the impact of market forces on everything, right? I mean, everyone practices in an environment, and one of the considerations is the market in that environment. I think that one thing that is going to clearly happen is that PFA as being a newer energy source, it will cease to have that label as competition fills the field. We have the lattice tip catheter, we have the balloon catheter, we have many others coming down. A lot of them integrated with mapping, and when a marketplace, when many players enter a marketplace and there's competition, the market
was good.
Yeah, the market will change.
Yeah.
Now, to your second point about cryo, we're here at EHRA. We have the Singleshot Champion release, which has a lot of different layers to it, comparing cryo and PFA with a loop recorder and experienced operators. Interesting findings. Design is not inferiority, but questions about is there superiority. Your take on the data and how that will impact some of these European centers that you described.
Yeah, but it addresses exactly the situation I've just been explaining. Cryo centers sticking to cryo and referring to Advent. Now we're going to say we have the Swiss champion by Reichlin and others being presented here at EHRA, published in New England. So it's obviously good data. And there's, for the first time, a superiority, not only in terms of procedure times or maybe one less complication, but really in terms of what matters the most for the patient, which is the rhythm stability and the rhythm outcome. So I think this data will enhance our trend to more PFA, and will maybe speed up this natural process that is taking place even in slow Europe. We are early adapters and obviously slow movers, but I think this will fire up the process and will speed up the whole thing. So I'm pretty confident that PFA will gain a more and more relevant role. And as you said, we have a greater variability of tools, so different catheter designs, different options in terms of mapping, yes, no, linear lesions, yes, no. So we will be soon able to cover every sort of arrhythmia using PFA, and I'm sure we will.
Thank you. So final two questions that I've asked everyone. Curious what your take is. First question, you need an AFib ablation. What energy source do you want and why?
So we agreed that I'm going to have an ablation, right? Okay. Yeah. Simple answer, it's going to be PFA. Just for all the things that we all saw from RF era, we all know it's super rare complications like esophageal fistulas, but still they happen. They are in my mind. Posterior wall ablation is always a concern, even though it's just a PVI. Still, the esophagus can be everywhere. We know that. So minimizing risk, not harming the patient, and that is very much in line with what PFA can offer. So my energy source would be PFA. Now you ask me for the operator?
If you want to share that, feel free. But my next question is, would you want your operator, whoever you determine that to be, to create a map?
I find it super helpful for me as the operator to know what my atrium looked like, what the atrium of the patient looked like. And if I was the patient, of course, this would be like, I don't know, 10-fold, 100-fold. I definitely want to know what if I have a normal, healthy atrium, or if there's any conditions that may require in the future additional procedures. Am I more prone to recurrences? If operator tells me you have a perfectly healthy atrium, you had dissociated activity in your left superior vein, I nicely isolated this one, and as long as the isolation will be maintained, you're going to be free of AF, I'd be so happy. So I need a map, guys.
Excellent. Well, thank you for joining us today.
It was a pleasure.
Lesion durability in PFA. We have several metrics that we've identified for improving that. Tissue contact being one, maybe a little bit of contact force. But you can't help but ignore the elephant in the room here at EHRA, which is the Singleshot Champion trial, which just came out. 210 patients randomized to the cryoballoon versus the pentaspline catheter. Initially designed as a non-inferiority trial, but reaching the threshold of superiority as analyzed in Kaplan-Meier curve. And so comment to me about those data in the context of lesions that are delivered in the area of PFA.
Yeah, I think that trial is a very important one. I think we need more randomized controlled trials that compare the different technologies and also the new PFA technologies that we have. And we are just starting to see the first of them coming up. With regard to lesion durability, we don't have data actually from this particular trial that was just published in the New England Journal of Medicine on durability, because that would probably take a redo procedure to really test it. What you do see, what was a little bit surprising to me, was that PFA did much better than the cryoballoon. Actually, the cryoballoon seemed to perform pretty poorly with a 50% recurrence of atrial fibrillation, which I thought was a little bit high in relation to what we know from prior studies. Now, that may have to do with the monitoring. In this case, an implantable loop recorder was used, so you pick up on a lot more AF, yes or no AF questions. But I don't know a lot about burden yet. I haven't been able to see yet what the protocols really look like, how many applications were done, and where were they done exactly. And maybe some centers are really very, very good with PFA to reach a better durability. There are some data showing that even in patients where you do a redo procedure, that the absolute number of veins that are reconnected is lower. And there's actually people that come back because of recurrence of AF, and when you go back in, you see that there's isolation of all veins. What you do also see is that when you look at these different durability studies, that there is a big range. So it ranges from 20% recurrence of connection or to 60%. So there must be more to it. There must be something with dosing, but also positioning of catheters. and not all PFA catheters are the same. The shape of the catheters is different, the waveform is different. So we really have to be careful to say, oh, PFA is better than cryo, because I think that there is more than one solution to deliver PFA. And we need to be very careful not to generalize these findings into every PFA is better than a cryo. I think we need a lot more data on that.
Yeah, I think strengths of the study, it showed that experience matters. These are experienced operators, as well as how we monitor matters too.
Absolutely.
And I think the loop recorder was an excellent choice there. And just to kind of piggyback on your point, yeah, PFA waveform is proprietary, as is the catheter, as is the catheter shape and polarity. And so, think of all the parameters that go into a PFA waveform: the voltage, the shape, the phase,
the duration, the number. It's an endless number of parameters that you can change or tweak to get more or less durability, but also on the other hand, maybe have more heating of tissue and things like that. So where are the constraints of PFA with the different technologies, and are we there yet with regard to dosing and optimal energy transmission?
And now we have a balloon-shaped catheter too that drives energy into the tissue and out of the blood pool. So with its own shape, with a single long electrode. So really, there's a lot to be written in the space, but I think it's a very exciting time to be an electrophysiologist.
What we then will obviously need to see is if mapping is really the game changer for increasing the outcome. Because what I would say is that, I mean, we talked about the trial today on cryoballoon versus PFA, 40% recurrence of AF. That's still, I think many people would say that's still not what we want. So we're not there yet. Even though we have symptom reduction, burden reduction, we want to really cure people of AF. So probably we need to see if mapping or ICE can really improve on our lesion durability and on our freedom of AF.
So I'm going to editorialize for a second here, just because I have not used fluoroscopy for my PFA procedures probably since my third PFA.
Okay.
I was an RF guy primarily before, didn't use fluoro. I was asked to use fluoro for the first few, then kind of did away with it. The map helps me identify the substrate, makes me, and I agree that in most people I determine I just need to do veins, okay? But not always. And the other thing is,
I would editorialize that as well, because I think that the proof that we have so far of anything we would do beyond pulmonary vein isolation is also still in a bad shape. I think we still don't know what we need to do beyond pulmonary vein isolation to help an individual patient. So we can do posterior walls or we can do lines, but I think that if anything, past trials have shown us that a standard procedure in a given patient with AF is not going to really help us that much. So I wish that mapping could help us identify the optimal substrate modification to really make a dent in freedom of AF. But so far it's been rather disappointing.
I mean, I think there's heterogeneity in the literature outside of the veins.
Absolutely.
No one can argue with that. So I want to switch my discussion also to talking about ice. It's a passion of mine. I think when you take the mental step from saying, okay, I'm going to go from the heart being invisible on fluoro to really a beautiful 2D and now even 3D potential with ice, I think you unlock a lot of diagnostic and therapeutic options. Understanding how your catheter is sitting in the vein, understanding the shape of the vein, understanding what the anatomy looks like, contralateral things. I think there's a lot to be unlocked with ice in Europe. I understand the fiscal constraints, but I just wanted to make that point. So I'm going to conclude with two questions. Okay. The first is, if you had to get an AFib ablation, what energy source would you want and why?
I would definitely go for pulsed field ablation. The reason being that I think that those procedures are so quick and so safe that alone would convince me to do it. So far, what we see is that the outcomes seem to be at least equal. And maybe, as we've seen in the recent Cryo versus PFA trial that was just published in the New England Journal of Medicine, maybe even better if an experienced operator that has done a lot of cases and knows what he's doing can do that. So I think currently PFA is the preferred ablation method for at least for any new AF ablation procedure.
Now, second question: would you want to map if you underwent an AFib ablation?
Me myself as a physician, or
Yeah, if someone were doing your ablation, would you want them to do a map?
depends on who's doing it. But I think that with an experienced operator, I would rely on their experience to do it any way they see fit. And I think that there you have to rely on the operator who's had good results. Would I do it in a poor operator that needs mapping to do it? Probably not. I would probably find somebody else.
All right. Okay. All right. Thank you very much for joining us.
It was a pleasure.
Yeah. And thank you all for tuning in to Hard Rhythm TV.